the epitome about the epitomic study, which has the potential to treat all degenerative brain diseases because they all have the same cause or mechanism of action. This involves using your immune system to create a fingerprint of your brain disease. The process of effective treatment and prevention is to measure, detect, identify cause, treat, and monitor. Here we go. So first, I'll talk about some of the treatment advances in Alzheimer's and other degenerative brain diseases. Recently, a study in Nature, the journal called Nature, in August, was a study of mice with Alzheimer's disease, and they looked at the lithium levels in their brain. The lithium levels, when they were normal, they help preserve cognition in aging mice. However, they noted that deficiency developed in these mice who progressed to develop Alzheimer's at both early on and later. And this deficiency got worse and worse and worse. By giving lithium, it also prevented the pathology and memory loss, again, in the mice. I don't have any patients who are mice, so I can't be sure that it's going to work in humans. What is known is that lithium does remove and reduce the tangles called the neurofibrillary tau misfolded proteins. And in the journal, they found that the formulation called lithium orotate was the most effective form, which is interesting because lithium orotate is over the counter, and the doses that have been used in clinical trials are around 5 to 50 milligrams once daily, with adjustments about every 1 to 4 weeks to get to the highest dose without a side effect. The reason it's interesting is that I started using lithium several years ago, and I'm not sure because you have to be able to distinguish its effect from many of the other treatments. So I still don't know for sure how it works in humans, which leads me to a caveat that translational medicine from the mouse to the human is not only tricky, but it's unpredictable. And this is a useful reminder of why some of the studies in the monoclonal antibody treatments for Alzheimer's were developed in mouse models. These are models, they are not accurate representations of Alzheimer's disease in humans. So I'm very optimistic about the epitomic study because we already have preliminary evidence in humans that antibodies of the type IgG inhaled through the nose have been effective in treating a number of different degenerative diseases in more than 300 patients treated for up to 10 years. Recently, we looked at the database and found that 27 people who initially met all the biomarker criteria for Alzheimer's, they no longer have it. Now, the next treatment, the potential treatment that's very exciting, actually has some human data, but they are case examples, but they are truly amazing. And this is the so-called heat shock protein. Heat shock protein, I'll tell you a little bit more about, but it was first identified to be effective in treating syphilitic madness by Nobel laureate Julius Wagner-Jauregg in 1927, where he took these neurosyphilis patients and gave them malaria to induce a fever, which activated heat shock protein and cured them from their neurosyphilis. The second example is another amazing one. It's an individual who was a Navy engine room operator who worked in a boiler room for most of his life. He and the rest of his family had a gene called presenilin 2, which is a very rapid onset, such that most of his family members developed Alzheimer's disease between the ages of 35 and 55. And he was the only individual in his family who doesn't have Alzheimer's, and it's 25 years after the expected onset. And in looking at why this gentleman might have not developed Alzheimer's, they realized that his job was in a boiler room, which uses temperatures of over 100 degrees centigrade, so that he was working for hours a day for most of his life. Well, it turns out these high temperatures, they activate heat shock protein, which actually prevented the formation of tangles in his brain. Even though he had some amyloid, it did not affect him. That's very exciting. Now, another example, again, basically based on heat, is a patient that was reported in the literature with progressive supranuclear palsy, which is a very rapidly progressive degenerative brain disease with no known treatment. This patient was reported to use heat therapy in a clinic in Florida, and they showed levels of the inflammation markers that had dramatically reduced for approximately 3 days, as well as an elevation of the heat shock protein for about 3 days, and reported some subjective improvement in function, as well as objective cognitive improvement. So this is another amazing example of a potential treatment of a neurodegenerative disease with no known treatment. Another one, even more surprising, is again an ALS patient who could not, so-called Lou Gehrig's disease. This patient was at the point where they could no longer swallow. They underwent heat therapy, and over time, they showed a marked increase in heat shock protein levels. They recovered muscle loss, and they are now able to golf and swim. I don't think I've ever heard of that before in ALS. So how does this work, this heat shock protein? Well, there's a variety of forms of stress that can activate it. There's thermal stress, such as a Finnish sauna, where you do the sauna and then you roll in the snow, get cold afterwards. There's antioxidants, so-called polyphenols, such as berries, resveratrol, curcumin, and particularly green and oolong tea. In fact, in Asia, where there's a high consumption of green or oolong tea, there is a lower incidence of Parkinson's disease. There's another way of stressing and inducing heat shock protein is metabolic, and that can be accomplished by fasting or caloric restriction 1 to 2 days a week. Another way that heat shock protein is activated is actually due to cell stress causing protein misfolding of damaged proteins in cells. This activates a variety of toxic species, such as reactive oxidation, cytokines, and other inflammatory molecules, which upregulate heat shock protein to unfold these misfolded proteins and either allow them to refold normally or to get rid of them entirely. Finally, mechanical or oxidative stress can be achieved by aerobic exercise or resistance exercise 4 to 5 times a week of moderate to high intensity, which means essentially that 30 to 45 minutes of exercise per session, to the point where you can get a little sweaty or short of breath. So this is focusing on the sauna approach because it's rather pleasant. The protocol that has been identified as effective involves a sauna session for 15 to 30 minutes. And this can either be done with a regular sauna or infrared sauna. With a regular sauna, that's temperature is 80 to 100 degrees centigrade. But for the infrared sauna, which penetrates deeper into the body, one only needs a 50 to 65 degrees centigrade or Celsius temperature to activate heat shock protein. These infrared saunas are now can be purchased and used in the home. Following the thermal activation, a cold plunge for 2 to 3 minutes at 10 to 15 degrees centigrade or Celsius will further boost the effect of heat shock protein. Now, it's important to realize that you don't want to do this every day because too much of it can actually produce harm and activate abnormal forms of heat shock protein. So a safe period of time between sessions would be between 3 and 7 days. So this begs the question of if these things are really effective for degenerative disease, what is actually causing the degenerative disease that these treatments are working on? Well, I'll show you some pictures as well, but the major cause of all degenerative brain diseases and degenerative diseases in general is excessive cell stress. Cell stress, I'll show you in the next slide, but it damages cell proteins, requiring the cell to respond by making new proteins to replace the damaged ones. And as long as that goes along, everything's fine. But if there's too much cell stress and the cell can't fully compensate, some of the newly made misfolded proteins start to misfold. And those misfolded proteins start to aggregate together to form very bizarre shapes. And if they're not removed, the cell dies. And that's the beginning of degenerative brain disease. These aggregated misfolded proteins, as I mentioned, they take on many different shapes and they trigger the immune system to make antibodies that recognize each of the different shapes. And no single antibody can recognize all of them. And that is important to realize because the pharmaceutical industry has been making what are called monoclonal antibodies. These antibodies recognize a single group of misfolded shapes, but they do not recognize the entire disease. And so the treatment results for the past 20 to 30 years have been kind of marginal, not super. And it's primarily because these monoclonal antibodies are only recognizing a small portion of the disease. The only exception to that rule is if a patient is identified extremely early when they only have a very limited set of misfolded shapes called amyloid. So I think we have come into a new era where with the ability to use the immune system, we can accomplish a diagnosis and treatment, I think, of all degenerative brain diseases that is patient specific. If correct, it won't matter whether you have Alzheimer's, Parkinson's, Lewy body, ALS, stiff person syndrome, progressive supranuclear palsy, frontotemporal disease, traumatic brain injury, chronic traumatic encephalopathy. It just doesn't matter because they all have the same underlying mechanism of aggregation of misfolded proteins. And then I'll show you visually what happens. So this slide basically points out that there are many, many sources of cell stress, and it isn't any single one that matters. It's the cumulative sum of all of them that matters. things like medical conditions that aren't well controlled, emotional, physical trauma, the loss of a spouse, a car accident, or playing sports, football in college or high school or professionally, acute illnesses such as COVID, stroke, seizures, traumatic brain injury, all of those stress cells and damage cell proteins. Environmental toxic exposures. They showed in Mexico City that smog increases the risk of Alzheimer's disease. Black mold also increases the risk of Alzheimer's disease and other degenerative diseases. Genetic factors. We talked about presenilin 2, and there's also a presenilin 1, which is also early onset. There's a late onset form of Alzheimer's that involves a protein called apolipoprotein E, or ApoE for short. And if you have the E4 version of that gene that makes that protein, it's very inefficient and doesn't transport cholesterol into the cell, which is required to make cell membrane. And it results in a tripling of the production of amyloid misfolded proteins in a person with one E4 gene. But if you have two, it increases the production by 9-fold. If you also happen to have had a head injury with loss of consciousness, it increases it by another 10-fold. So you could be looking at a 90-fold increase in persons who have two E4 genes and a head injury with loss of consciousness. I recently have been evaluating retired players from the NFL. And what's astounding is when I take a history to calculate the number of hits that they have in their career. And the estimate has varied from 40,000 hits to 400,000 hits in their career. Now, what is a hit? Well, they've done physical experiment to show that a hit is equivalent to moving a ton of cement a yard. Imagine multiplying that by 40,000 or 100,000. That's what happens to their brains. So these sources of stress, they add up and they damage proteins, which must be replaced with new ones. And on the left-hand side, you see the normal process where the nucleus makes a new protein, then it's folded into the form that it's needed to hold in order to function properly. Then it's transported to the site of damage and replaces the damaged protein. But if the stresses exceed the cell's capacity to replace the damaged proteins, then errors in folding, step 2, occur. And these errors result in misfolded protein shapes. And on the right-hand side, where it says misfolded proteins aggregate into many shapes, these are just a few examples of the bizarre shapes that proteins can aggregate together and form when they are misfolded. Again, on the left-hand side, you see again those misfolded shapes that are aggregates of many misfolded proteins. And if they're not removed from the cell, they then attach to the cell membrane and they block the flow of traffic in the membrane and kill the cell. So your immune system is brought in, comes to the rescue. And what it does is it identifies all the different misfolded proteins in your brain, and it makes an antibody for each group of these misfolded shapes. It then goes into the cell and it binds to them. These red guys are the antibodies. It binds to this misfolded protein aggregate and removes it from the cell and from the brain. And as long as that can keep up with these misfolded aggregates, everything's still normal. But when the misfolded aggregates in the brain exceed the immune system's capacity, that's when degenerative disease begins with cell death. So from my perspective, something I've learned over the last 10 years about now is that by measuring the amount of disease in the brain and then initiating a treatment and then remeasuring the amount of disease after a period of 1 or 2 years, we find that either the misfolded protein numbers have stayed the same, and in those cases, the individual has not gotten worse and remained stable. If we've actually seen a reduction in the misfolded proteins, we find that patients will partially improve. It is only when patients are not treated with agents that actually remove these misfolded aggregates that the numbers increase and patients get worse. And this is going to be the most common scenario because there are not too many physicians who know what actually does lower the misfolded proteins and block their production. Taken me a long time to learn that by trial and error, but measurement has been key. So this year, after about 6 years of work with Dr. Charles Glabe at UC Irvine, we were able to begin what's called the epitomic study. And what that study does is takes a sample of blood from each patient and can identify the fingerprint of the disease in their brain using their own immune system. This is a key to individualized diagnosis and treatment of, I think, all degenerative brain diseases. And here's how the whole process works. We have about 500 patients in the clinic, and our goal is to raise adequate funding to be able to do every patient in the clinic, as well as many of their family members as possible. They come in to the clinic when we bring in a phlebotomist, somebody who draws blood, and they take 1 tube of blood. And we send that tube of blood from each person. We send that over to Dr. Glabe's lab. And in his lab, he has these arrays of 1,000 wells. Each well has a differently shaped misfolded protein in it. So when we pour a person's blood onto that array, the antibodies in that blood that recognize a particular misfolded protein will bind to that well. And in the slide I'm showing you, the color represents the antibodies in a person that have recognized a misfolded protein and have bound to it. Well, this literally is a fingerprint of the disease because your immune system is taught to recognize all the different shapes. So it doesn't leave anybody out. By defining this fingerprint, that gives us the potential to use those antibodies directly to actually treat the person's brain disease and to treat all of it. And it doesn't matter what degenerative disease it is, as long as we can identify those misfolded protein shapes. On the left-hand side is an example of a single patient with Alzheimer's disease, and each line of letters says unique aggregates above it. That line of letters represents a particular misfolded protein that has aggregated in bizarre ways. And on the left side is a bluish row. That row represents a specific antibody that's been developed to recognize that particular shape of misfolded protein. Typically, an Alzheimer's patient will have anywhere from 20 to 100 different antibodies to recognize all the differently shaped aggregates of misfolded proteins that cause these degenerative diseases. Now think about it. The pharmaceutical industry is making monoclonal antibodies like Kinsella and Leqembi, and they are extremely effective at removing what they remove. Unfortunately, they only recognize a few of these misfolded protein aggregates. The rest aren't touched. And the result is that the trials that have been done over the last 20 to 30 years have been very marginal in the benefits for these treatments. And the reason is that these antibodies don't recognize a large portion of a person's brain degenerative disease. There's really only one possible exception, and that's if you can catch a person so early that they only have a small set of misfolded proteins that are recognized by one of those FDA approved antibodies. In that case, you can get a dramatic result because there's no other disease to remove. I've seen one or two patients like that. Unfortunately, one of the patients had a family member who had a brain hemorrhage from these treatments. They each carry a risk of brain hemorrhage that is somewhere on the order of 25% or higher. These brain hemorrhages might be tiny and unnoticeable, but they can also be large. And so one has to face that particular risk if one is going to try this treatment. I don't think it's worth the risk, particularly given that it's not treating the majority of the disease. The drug companies don't particularly like me for that reason. Now, I want to drive this point home. We think of amyloid as a single thing, but Dr. Glabe and others have shown that there's actually 8 different classes of amyloid with different structures, different superstructures. And these classes of amyloid structures can be composed of many different types of misfolded protein. It could be amyloid, it could be tau, it could be alpha-synuclein. There's a wide variety. So even though they're called amyloid, they could actually be composed of misfolded proteins that are not amyloid. So again, this is why you have to be able to recognize at least 8 different classes of shapes. And remember that these shapes, they can aggregate with other misfolded aggregates in any way they want to. So it's a lot more than just 8 antibodies that need to be produced. Finally, I'll come to what we hope, and I think we've got enough evidence to be able to move to part 2, which is an FDA clinical trial in which we use each patient's antibodies to identify their brain fingerprint of their disease, and then using widely recognized methods of extracting those specific antibodies, which have been done for 50 years, we extract that patient's specific antibodies, as well as if we have family members who are also participating, they often will have the same antibodies, but because they don't have symptoms, they will have some antibodies that are much more effective in larger amounts. And as a person gets closer and closer to symptoms, the most effective antibodies start to decrease and less effective antibodies start to increase. So by evaluating the blood of children and other siblings, even the spouse, we can identify, well, we hope to identify the most effective antibodies for each person. Now, Dr. Glabe has already accomplished a lot of that in Alzheimer's disease, so we know he can do it for that. I'm pretty confident that we can also do it with Parkinson's, Lewy body disease, traumatic brain injury, very common degenerative diseases. And it's harder to do this in rare degenerative diseases, but I think with the proper methodology, we can also do that. Now, if we achieve this, and our goal is to be able to get to the clinical trial within 18 months, I think that's probably optimistic, but I won't stop being optimistic. Imagine that what I'm currently using are commercially available antibodies, many different types, derived from thousands of blood donors. And in these blood donors, they have many different types of antibodies, but only 5% of them actually target brain stuff. Okay, 5%. Well, with that 5% is what I have seen the most effective treatment in my career is this intranasal delivery of these antibodies that are commercially available. Well, this treatment with the patient's own antibodies identified as the ones that are targeting their disease, we will be using 100% of the antibodies to treat them. And not only is it 100%, it's 100% of the patient's antibodies, very specific, because different people with Alzheimer's have different sets of antibodies. Well, just mathematically, if you're going from 5% targeting brain to 100% targeting brain, that's a 20-fold increase in removal of disease. We can remove 20 times as much disease. But if we also make it patient specific, that could be able to remove as much as 100 times of the disease as what we can do with currently what I found to be the most effective treatment, which is pretty effective. So this is really exciting. Doesn't matter what the degenerative disease is. That's our hypothesis. So the research goal of the epitomic study is to build towards more effective treatment for many, if not all, degenerative brain diseases. And the roadmap to curing these degenerative brain diseases is one, to identify each person's fingerprint of their brain's immune pathology, then two, use their immune system's fingerprint to treat all of their degenerative brain disease, whether they have symptoms or not, because these diseases go on without symptoms for 2/3 of the total duration. So there's a long period with no symptoms at all. And if we can identify people during then, I think prevention is imminently possible. So this is our proposed timeline for the study. Initially, we have already begun sampling blood from each clinic patient. We estimate that there will be about 2,000 people that will have blood sampled, the 500 patients, and as many family members as possible. We'll use the family samples to help identify the most effective antibodies. We'll then identify a vendor that's FDA approved to extract those antibodies based on each patient's profile. Then, with a colleague from University of Indiana, who's a super expert in what's called Bayesian basket trials, we will design a basket trial to treat multiple degenerative diseases. This is permitted by the FDA as long as these different diseases have a common mechanism of action, which we believe to be true for all degenerative brain diseases. Then we will apply to the FDA to do a clinical trial of what are called autologously derived antibodies. That means taken from the blood of the patient or a family member. Then we initiate the clinical trial, hopefully at month 18. We monitor for effects and analyze the interim and final results. If they are successful, which I am pretty positive they will be, I don't think we'll continue need to extract blood from patients and family members. I can't imagine there isn't a company that would love to be able to get a prescription from doctors of the patient's brain fingerprint, make those antibodies, and send them to the patient and family to treat them. I just can't imagine there's not a company that would want to do that. So we set up the nonprofit foundation. It's called the Foundation of Memory. And our goal is to find effective treatment for all degenerative brain diseases. Be happy to answer questions.
Thank you, Dr. Shankle. That was very enlightening. I have a couple questions already that I would love to ask. So one person asked, how will potential participants be chosen? Are there residency requirements? Is there a certain
Yeah,
disease progression? I'm not sure if this question is particularly about the first phase of the epitomic study, which is really just the blood sample and is open to, anyone who
yeah.
wants to participate, but it sounds more geared towards potentially part two, where there would be treatment.
If I have a patient or family that says, can we participate? The answer is yes. There is no, see, I was a statistician before I became a doctor. And one of the biggest mistakes in clinical trials is to exclude patients by certain criteria, because a doctor doesn't get a chance to exclude people that have certain conditions. So the results of clinical trials done that way are almost never representative of what doctors will experience when they actually use those treatments. So I do not believe in excluding anybody in the clinic to participate if they want to.
Thank you. Another question is that, medicine is notoriously slow, especially with bureaucratic hurdles and the FDA. Do what is like a realistic timeline, a pessimistic time? What are some timelines for how long it'll take to get to a treatment phase?
Um, Let me go back. So I've looked at what are the potential time delays of this timeline. One is getting the vendor approved to extract the blood. There's a certification process that they must pass, and I don't know how many months that might take. That could delay the trial. But that's why we're not waiting for the beginning of the trial. We're gonna start doing that as early as we can. The second is to get FDA approval of the trial. Obviously, with the recent change in administration, most of the senior members of the FDA have left. And so there's a whole new cadre of individuals. So there's more uncertainty about the timeline for getting approval. But one nice thing is that an autologous trial, the criteria for approval are less stringent than a trial where medicine is synthesized or created. So that should help. Um, I can't predict those two steps, but those are the two steps that could really cause delays.
It does seem like the FDA likes to accelerate trials for, treatments that where there is no treatment. So that is potential. You could potentially speed it up that way too.
If
Um,
we include, we are going to include patients with rare diseases, and there is a special category to accelerate the approval of rare diseases. So that may benefit us.
okay, so one other question, Dr. Schenkel, is will this antibody treatment have some of the same risks that the existing monoclonal treatments have?
Good question. And the answer is I don't think so. I've used, like I mentioned, I've used the commercially available antibodies from manufacturers for 10 years now, actually for 20 years, if I include when I was giving it through the blood intravenously. And in the last 10 years, over 300 patients treated, I've had zero serious adverse effects when given intranasally. And that is probably because the nose has very little of a blood-brain barrier. There's a barrier, but it's not the blood vessel. When you give antibodies through the blood, they have the potential to bind to amyloid in the blood vessels. And it's like pulling plugs out of a dike. Okay. That's where the hemorrhage comes from. So if you're not giving it through the bloodstream and giving it intranasally, to date, I have not seen a single case of brain hemorrhage from that. And I have treated people with pretty severe, what's called cerebral amyloid angiopathy, which means their blood vessels are loaded with amyloid and they get lots of microscopic hemorrhages in their brain. It can look like Swiss cheese sometimes. But even treating those people, I have not seen an increase in that when I give them intranasal antibodies. And unfortunately, I've gone to Lilly, Azi, and Biogen and challenged them to do a head-to-head trial of their drug intranasally versus intravenously. They all said, no, we don't believe it. Okay. Even though there are studies to show that in the blood, when you deliver antibodies, only 0.1% of those antibodies get into the brain. 99.9% are wasted. In the nose, when they give direct comparison with the intravenous delivery, up the entry into the brain was up to 1,700 times higher than delivered in the blood. And that's why I do it intranasal.
I know you're hoping to publish a little bit about that in 2026 as well. Um, Thank you for answering that question, Dr. Shankle. We have another question here where someone is trying to understand a little bit more about, what you mean by a family member of the patient. Can you talk a little bit more about that? Like, is it a biological family member? Do they share some of the same immune system? What is that? What's going on?
Well, I apologize. Family members would be brothers, sisters, aunts, uncles, parents, grandparents, children, grandchildren. And what Dr. Glabe has found in adult children of a patient with Alzheimer's, where the adult children have no symptoms at all, is that the majority of them have a similar set of antibodies as the patient with symptoms, but their antibodies are loaded with the more effective ones. And as as they get closer to symptoms, the most effective antibodies decrease and less effective antibodies increase. So did that answer the question?
I think so, yeah. Thank you, Dr. Shankle. Let's see. Someone is curious if not sure I've heard of this ibogaine. Might be some kind of pharmaceutical. Have you heard of ibogaine, Dr.
How do you
Shankle?
spell it? How do you spell it?
Ibogaine. It's a psychoactive compound. I guess the one broader question we could ask is like, are psychoactive compounds helpful for AD? I know that it's very in vogue right now to use
Yeah.
ketamine therapy for PTSD. Various, people are really interested in hallucinogens to treat depression. What have you seen anything that helps for AD or other diseases?
Well, one essential problem in answering that question is that it's extremely restricted to gain access to psychoactive compounds like LSD, magic mushrooms, etc. Okay, so to be able to do that research, there's only a few centers that are approved to actually prescribe those in humans. So that's a limiting factor. But I would give you a general answer to any treatment. If you can measure the disease, the amount, you can give a treatment, and then after a period of a year or two, remeasure. And if Disease load has decreased, and that's the only treatment that changed, then I think you can be confident that it works. If the disease load has increased, and that's the only treatment that was changed, you can be confident that it doesn't work.
Thank you, Dr. Shankle. We've got a couple more questions that have come in. So someone is curious if, you know, does misfolding, it seems like some protein misfolding is the result of genetics, right? People who have APOE4, that raises your risk for AD. If you have APOE2, it's protective. If someone has siblings who have no symptoms but have a similar set of antibodies, would potentially this epitomic, intranasal treatment only address the misfolding that is due to genetic factors, or would it address misfolding due to all factors?
A good question. So, if I understand correctly, the question is related to if misfolded proteins are produced by genetic mutation, that's one source. But if they're produced by a head injury or diabetes that's out of control or something else, some other source, do the does the treatment also recognize that, or does the epitomic study recognize those other sources of misfolded aggregates? The answer is yes. The immune system doesn't care where the misfolded protein came from. Once it's there and it's not removed, the immune system is activated to get out its big guns and go get that guy and get rid of it. So any source of protein misfolding is addressed by the immune system.
Thank you, Dr. Shankle. It does seem like a lot of people are very interested in that in phase 2 where treatment takes place potentially. Are you, how are you going to enroll people? Obviously this is, preliminary, so it's hard to speak to what the reality will be in 2 years or whenever. But, does the duration of the disease or where, someone's severity, is that going to impact whether or not they can participate? Are you going to enroll people of multiple severities?
I can tell you, first of all, I don't care what severity it is. Okay. If it's more severe, there's probably more misfolded proteins. And that's actually a greater justification for using a treatment that can remove 20 to 100 times as much disease. So severity has nothing to do with it. Again, I don't believe in excluding anybody who's a Shankle Clinic patient, and even if they don't have a family member, I still wouldn't exclude them, because if, let's say, they have the syndrome of Alzheimer's disease, Dr. Glaive has identified some of the antibodies that are the most effective against Alzheimer's misfolded proteins. So there's no reason to exclude anyone. In fact, I think it's unfair to do that, because if you really want to test the efficacy of a treatment, you should not exclude anyone.
Thank you, Dr. Shankle. That's very helpful. We have another question that came in. Someone who has, some gut microbiome issues. They have a compromised immune system, and SIBO has attacked their gut microbiome and impacted their brain performance. I've read that a lot of the immune system is actually in the gut, I believe. Yeah, maybe that's right. But anyways, are there I guess the larger question, the specific question is, are there certain cases where, someone who's immunocompromised is going to not be able to take the treatment, is going to be less effective, or would someone who has a compromised immune system actually benefit, in these secondary ways by
Yeah.
by taking the treatment?
So another good question. If you're immunocompromised, that means you have a deficiency of the immune system. So that if you are able to amplify the antibodies that are important in treating your disease, that can only be beneficial. And to point out the other aspect of the question, uh, this points out a very good example where somebody has the small bowel uh, intestinal overgrowth condition. That does affect the brain because it's a medical condition that's not completely controlled. And every organ in the body has to work with every other organ of the body for the body and brain to function together. And the orchestrator, the conductor of the whole system, is the brain. So when a kidney starts to fail, that affects the metabolic environment of the brain and it affects brain function. If a person develops cancer and is given chemotherapy, that can cause various symptoms such as fatigue. And this chemo fog is definitely a consequence of the chemotherapy affecting brain function. You can think of any disease that is not controlled, it's going to affect brain function. I usually test people who've recently had a urinary tract infection, and they almost always show a decline in their cognitive function for some period of time after the urinary tract infection. So, was able to adequately address that?
I think so, yeah. And maybe we'll just do one last question. Can you go over the cost for the treatment? And then just stepping back, um,
The cost of the
what
treatment?
the cost of the treatment. I know that one really important part of your mission, with the INIG has been to make it more cost effective relative to the monoclonal antibodies.
A while ago, I put together a comparison of intravenous antibody delivery to intranasal. And this is not the approved monoclonals. This is the commercially available antibodies derived from thousands of donors. And if you look on the intravenous side, the the cost because of the dose given is somewhere between $8,000 and $18,000 a month. And that's because, for example, in a 90 kilogram person, they're going to require 70 grams a month intravenously because only 0.1% of those antibodies get into the brain. Okay. Now, in the same patient, if I give it intranasally, it goes from 70 grams a month to 2 to 4 grams a month to get an effect that's either as good or better with fewer side effects and no serious adverse effects in any patient I've had for the last 10 years. So that reduction in dose drops the cost to somewhere between $300 and $600 a month. For typically the antibodies cost about $150 a gram. So that's where this 300 to 600 a month comes from. I don't know what the most recent estimate of the Kinsula and Leqembi are, but I think it's on the order of $20,000 to $30,000 for the treatment.
For
Is
a
that
year, yeah.
roughly?
for a
Yeah,
year.
and
Yeah.
obviously some of it is covered by Medicare, but it's not cheap and it carries a higher risk.
Well, thank you, Dr. Shankle. And yeah, thank you for the lecture and for answering some of these questions.
My
And
pleasure. My
thanks for
pleasure.
joining us, everybody. We'll
Yeah.
we'll try to do another webinar early next year, hopefully sharing some research results or on another topic of interest. So thank you, everyone.
Bye bye.
All right, take care.
Okay.